Bowel management assessment and interventions in SCI populations are easier than you think. Stick around to see how you can easily incorporate them into your practice. Welcome back to video number 7 in the series, where we discuss the role of OT in BBM. I'm Julia, and today we'll discuss how to develop an OT-specific plan of care for managing neurogenic bowel. Specifically, we'll cover how to add a non-standardized bowel function assessment to your plan of care, common toileting barriers by SCI level and how to address them, and examples for short and long-term goals for your clients. Supplemental handouts and resources are linked in the video description below. Let's get into it. So to kick off this video, let's talk about the big picture. What exactly are we trying to accomplish with the bowel management program? The overarching goals are to maximize independence in toileting while preventing secondary complications like constipation, fecal impaction, and autonomic dysreflexia, or AD. Why does this matter? Because better bowel management equals less time in the hospital dealing with preventable complications and a better quality of life. Now, here's the good news. Just like my previous video on non-standardized bladder function assessments, you don't have to reinvent the wheel or add a ton of extra steps to your initial evaluation process. By simply shifting your lens to include bowel function, you can gather everything you need while conducting your standard OT assessment. Note, if you watched video 4 on non-standardized bladder assessments, feel free to skip ahead to this timestamp to go straight into the non-standardized bowel function portion of this video, as the beginning of this module will be a bit of a review for you. Otherwise, let's roll straight into step 1. Okay, so just like any other evaluation, we start with the chart review. Here, we gather key information about our client's level of injury and motor sensory function using the Asia Impairment Scale. As you probably recall, spinal cord injuries are classified as either upper motor neuron or lower motor neuron lesions, which directly impacts bowel function. So, injuries at or above T12 equals upper motor neuron lesion, resulting in reflexive or spastic bowel, whereas injuries below T12 equals lower motor neuron lesions results in areflexive or flaccid bowel. Seems straightforward, right? Well, not always. While these classifications are helpful, injury level alone doesn't always tell the full story. Some individuals may have additional lower motor neuron involvement due to concurrent injuries, or still may be experiencing spinal shock, a temporary condition where reflexes are still absent. These conditions can alter bowel function, meaning a person with an injury above T12 may still present with an areflexive bowel. This is why we never make assumptions and always collect additional information during our evaluation and through our non-standardized bowel function assessment, which will be discussed later in this video. Now, let's shift gears and talk about hand function. Bowel management is about more than just bowel function. It's also about whether the client has the dexterity and the motor control to perform their bowel program. Individuals with SCI typically fall into 3 functional groups based on hand function. We have C1 through C5, typically presenting with absent hand function, requiring full to max assist for bowel management programs. Next, we have C6 through C8, typically presenting with limited hand function. This group has the potential for full independence in bowel management programs with adaptations. And finally, injuries T1 and below typically present with full hand function. And with this group, bowel management programs is typically fully independent and achievable with little to no adaptations. Knowing all of this ahead of time helps us predict challenges and plan targeted interventions. Next, we dive into the evaluation and occupational profile. We already routinely assess home setup and support systems, so consider these environmental barriers to toileting early on. Setting up a mock environment in an ADL suite can help clients practice toileting tasks in a more realistic setting later in your plan of care. On to our motor function assessment. This tells us where the client is starting in their recovery journey. We direct our focus on upper extremity range of motion, strength, dexterity, and trunk control. The presence of functional tenodesis is game-changing, starting at the C6 level, as it will support gripping needed to manage digital stimulation, or enemas. Additionally, we want to observe if there's any spasticity that's observed, as lower extremity spasticity can affect body positioning needed for lower body clothing management or the bowel program itself. Finally, observing ADL performance will also help us identify limitations and where we need to start with toilet training. For example, not only watching a client perform the ADL of toileting, but also dressing, transferring, and functional mobility helps identify other challenges that the client may have with the smaller tasks of bowel management. Now, on to our new step of adding a non-standardized bowel function assessment to our OT evaluation process. This assessment will take the form of a clinical interview to explore what their current management looks like for their program. Key areas to address include current bowel routine and independence, sensation and bowel movement symptoms, and complication and risk factors. For current bowel management routine, we want to know what is their current bowel program, whether it's digital stimulation, suppositories, enemas, or transanal irrigation, and who is performing this? What is their schedule? And what was their bowel movement timing and frequency prior to injury? Does the current schedule support what their body is used to? Next, for sensation and bowel movement symptoms, we want to know, is there any sensation for bowel fullness or the need to have a bowel movement? Are they experiencing accidents or unexpected bowel movements? If so, how often and under what circumstance? And are there specific triggers for accidents like transferring, eating, or the time of day? And lastly, for complication and risk factors, are they experiencing pain, discomfort, or spasticity during their bowel routine? Once we've collected all the necessary information from the evaluation process and the non-standardized assessment of bowel function, we should have a pretty good snapshot of where they are in their bowel management journey. So let's move on to common barriers that clients face when trying to manage their bowel programs. Common challenges seen at the stage include, but are not limited to, anxiety with the prospect of performing the bowel program, limited understanding behind the mechanism of bowel reflexes and how to stimulate them, limited upper extremity functionality and trunk stability to support sitting upright and transferring over a toilet, bed mobility, and body positioning for side-lying programs, AE use or insertion of suppositories or enemas, and lower extremity positioning and lower body clothing management. Presence of lower extremity spasticity can affect body positioning or poor visualization due to lighting. Enter occupational therapy. To address these barriers, we can structure our plan of care around three main intervention approaches: create, promote, establish, restore, or adapt and modify. Through create, promote, we can educate our client about the bowel system, basic anatomy, importance of a bowel management routine, and how it helps prevent complications like constipation, impaction, and AD. Trauma-informed care is also key in this area by validating potential fear and anxiety along with proper teaching, explaining step by step what they're doing during their tailored bowel program, along with what to expect, can help ease the client. Of course, really, it just comes down to compassionate care. Next, we have the bowel movement schedule. We can team up with the nursing staff to create a personalized bowel movement schedule, including initiating bowel program time, medication administration, and digital stimulation or rectal sweep. Pro tip: pairing program timing after meals or drinking warm prune juice or coffee 30 minutes prior can help facilitate bowel movements. And finally, introducing the concept of a bowel diary, noting items like stool form using the Bristol stool form chart can help identify trends needed to adjust the bowel program from there. Next, through Establish Restore, we have therapeutic exercise and activities for strengthening and improving coordination, which are both needed for body positioning, transferring, and seated balance training to support safe and efficient bowel programs. Lastly, through Adapt and Modify, we get to be creative and find individualized solutions for our clients with AE or activity modifications. Some examples of AE to consider include a dill stick, suppository inserter, adaptive toilet paper wiper, or a bidet. Some modifications include different body positions or environmental modifications like using a padded 3-in-1 commode or a padded raised toilet seat. By combining these strategies, we help clients feel more confident and more independent in their bowel management programs. On to long and short-term goals. We already mentioned at the beginning of the video that the goal for clients is to maximize independence in toilet. However, some specific goals that you can include in your documentation include the long-term goal: client will independently perform their bowel management program using adaptive equipment, for example, a suppository inserter, in a seated position within 3 weeks to support full independence in bowel management. A short-term goal to support this could be client will maintain upright seated balance using one-handed upper extremity support for at least 2 minutes within 2 weeks to improve independence in bowel management program. Or another short-term goal to support this could be client will demonstrate proper digital stimulation technique using adaptive equipment and appropriate body mechanics with minimal verbal cues within 2 weeks to improve independence and safety in bowel management. Before we wrap up, I want to mention that some clients may need long-term bowel management options, like ostomy bags, depending on their level of injury or their inability to perform a bowel program within a reasonable time frame. In these cases, goals should focus on training and ostomy bag management, such as emptying, cleaning, and resealing to improve independence in toileting and personal hygiene. Now, I know that was a lot of information, but here are 3 key takeaways. A small shift in the evaluation process is all it takes to integrate bowel management into OT practice. A non-standardized bowel assessment conducted through a clinical interview helps guide the plan of care. And finally, a mix of intervention approaches ensures a client-centered approach to toileting independence. If you found this video helpful, be sure to check out video 8, where I go into a little more detail on various AE used to support bowel programs. See you there.